Mary, can you hear us?
Yep. Can you see me?
We can't see you, we only can hear you.
Well, how do I do the? There, I can see all you guys now. What do I need to do? Hello?
Doesn't look like the video camera is working, so you might just have to talk. We have a picture up, so that's probably the best we have to do right now.
Okay. Well, how did you guys get on there with their paces? What do you got to do?
I think you might have signed on to the, or I don't know.
We've all been having a little trouble with the technology. It's not, it hasn't been super smooth.
Okay.
For mine, Mary, there's a green round button that has the video cam, and you click it so that it shows your camera.
A green button. No, that's
That
the
looks-
heart. What's that?
Looks like a video
No.
cam.
This MNA thing is in the way. There, move that.
Oh.
Move that out of the way. Audio. Webinar information.
There should be a box that says like webcam, audio, attendees, chat.
All right, and it started already, so people are signing in right now, so they can hear us.
Rob, I'm troubleshooting with Jenny, and I think she never did get the panelist email because we had an old email address for her. Is it possible to resend that to her?
Yeah.
Okay.
Now you're on, Mary.
Oh, there's Mary.
You're on mute, Mary.
Can you unmute yourself, Mary? There you go.
Oh, there you go. Yeah.
There you are.
Yeah. Are we starting already? No, we're not starting yet.
No, you got
3 minutes.
3 minutes.
Okay. No, I said if you poke at the screen long enough, you finally figure it out. It's like,
No. Okay. So it looks
Hi,
like
Chris.
we have a lot of folks already on the call. We'll get started in a few more minutes. Oh, there you are. Okay. So it's 4 o'clock, and we'll maybe give folks a minute or two longer to sign on. We're expecting quite a few nurses to be on this call today, so we'll give people just a couple more minutes. Expecting quite a few nurses to be on
Hello?
this call today, so we'll give people just a couple more minutes.
We're being recorded.
Expecting quite a few nurses to be on this call today, so we'll give people just a couple more minutes. That was. Expecting quite a few nurses to be on this call today, so we'll just a couple more minutes. Expecting quite a few nurses to be on this call
Is-
today, so we'll just a couple more minutes.
Jerry, is that going to play the whole time?
I certainly hope not. It looks like Rob is troubleshooting that.
Okay, very good. Jerry, is that going to play the whole time?
I
Oh,
certainly hope not. It looks like Rob is troubleshooting that.
Okay, very good. Jerry, is that going to play the whole time?
I certainly hope not. It looks like Rob is troubleshooting that.
Okay, very good. Jerry, is that going to play the whole time? Oh. Okay. Jerry, is that going to play the whole time? Oh. Okay. Jerry, is that going to play the whole time?
Jerry, can you try just exiting out and coming back on?
Yeah, that might work.
Jerry, can you try just exiting out and coming back on?
Wow. This is going to be, yeah, that might work.
Jerry, can you try exiting out and coming back on?
Wow. Yeah, that might work.
Okay, did that solve the problem?
Sounds
Okay.
like it.
All right. Well, it is 4:04 and we have quite a few people joining us now, so we can get started. We'll first have a welcome from MNA President Mary Turner.
Good afternoon, nurses. My name is Mary Turner. I'm the president of Minnesota Nurses Association, but more importantly, I'm also a bedside care nurse on a medical surgical floor ICU at North Memorial in Robbinsdale. And I happen to be the floor that is the first of our ICUs to be the COVID-19 floor. So I feel I think I've told some news people that my emotions vacillate between sad and mad, with an underlining tone of perpetual anxiety. And I think I speak for all of the nursing for sure and the healthcare professionals when I say that we are all experiencing this underlining anxiety. That being said, I am doing my utmost best to represent us not only on the governor's task force, but also on the media with whoever will listen, to get our message out as to what we're experiencing on the bedside and what our concerns are. And so by land or sea or air, I'm trying to get out there everywhere to tell our story, because it is so important. But I will say that I am so proud of the job that our organization is doing to address this public health, unprecedented public health crisis. I couldn't be prouder of the staff. And you're going to hear from some exceptional people today that I can't say enough about how wonderful it is to work for them and how fortunate we are to have them working for us, the nurses. And with that, I'm going to turn it over to Jerry Katz, who will MC this. Thank you.
All right, thank you, Mary. So if we'll go to the next slide, we'll just see, this is the agenda that we're going to be sticking to for this program. So the first thing we will do is hear from the 3 practice experts on the MNA staff. And the first is Kristina Maki, who is our nursing education specialist. You're still muted.
Kristina, you're still muted right now. Kristina, hit the mute button one more time.
Oh, am I live? Can you guys hear me? Okay, so to everyone out there, hi, my name is Kristina Maki, and I am a staff member here at MNA. I work in the education department. I am also a practicing MNA nurse, so I still have a casual position at Children's. And so this is really a crisis time, and I feel everyone's pain because I see it in practice also. One of the things that's been a particular challenge for me, coming from an education background, is we are trained and I always look at using evidence-based practice and peer-reviewed articles and research. And the research and the articles are coming at us so fast, but because this is such a new virus, there's not a lot of real hard and fast scientific information that we can give to you. So that's why we're really emphasizing as a practice department that we utilize the precautionary principle. And that, to be honest, is kind of a new term for me. I had to go back and really look at it. So what that precautionary principle is, in essence, it's stating that we err on the side of caution when we're facing the unknowns. It's kind of, for lack of a better phrase, it's a better safe than sorry. We really need to use that precautionary principle, which states that when we're lacking scientific consensus, that any type of action, a policy, or an act is not harmful, especially when that harm has the potential to be catastrophic, that we don't utilize those actions and we go with the maximum safeguards that we could possibly utilize. And what we're seeing out in practice right now is standards are being changed based upon supply and not the actual science that we have. We know when we look at other countries that the guidelines that are set forth by the CDC and by the WHO to begin with weren't high enough, and they keep lowering those down. So we really need to be looking at this precautionary principle and utilizing the best protections that we have available. So then we start talking about the PPE shortage, and there's a lot out there right now. We've been hearing as a practice department about PPE being locked up, which is absolutely ridiculous. What's going to happen? So if they're locking it up for surge, but in the meantime, our nurses aren't protected taking care of patients right now, those nurses will not be there to take care of patients when that actual surge hits. The next thing that I wanted to hit on real quickly when we're talking about PPE is that's a last line of defense, and there's a lot of things that our hospitals can be doing with environmental controls to protect us as healthcare workers and to protect the patients. So there's things above and beyond restricting access to PPE. We have to look at increased emphasis on identification and implementing source control. We need triage protocols that detect and isolate potential cases of COVID-19 before or immediately upon arrival to the healthcare facility. We need to limit the entry into the facilities, and we should have policies to limit and screen visitors. Hospitals should be putting up barriers in reception areas, physical barriers or partitions to guide patients through the triage, and triage stations potentially outside to screen those patients. We need to look at masking patients and putting patients in ways that minimize contact with employees. We need to look at having dedicated transportation routes and routes of entry with source control for not only patients, but also for workers and environmental cleaning and all the rest of the staff. And finally, when we're talking about environmental controls, we should not be having patients with the potential or diagnosed COVID-19 assigned to the same nurse that's taking care of those patients that aren't. It's absolutely ridiculous that we're doing that. So then we get into the fact, what's the highest level of protection? And honestly, we know the highest level of protection is having that PAPR, is having gowns, is having gloves, temporary scrubs that we leave at the hospital and are washed there so we're not bringing it home to our children, to our family, to our loved ones. When that PAPR or that capper is not available, the minimum, the lowest level of protection that we need is that N95 when we're taking care of those potential or positive COVID-19 patients. A surgical mask might be effective in blocking those big splashes and those large particle droplets, but a face mask by design does not filter and block those small particles in the air that are transmitted by coughs, by sneezes, and by certain medical procedures. They also don't give us complete protection from germs and other contaminants because of that loose fit on the surface of the mask and of our face. So the optimal gold standard, the way that I taught my nursing students when I had them, is that one disposable N95 mask that you use it with the one patient and then it's done and you get a new one with that next contact. But we know in actual practice that that's not being used right now. In light of the situation we're facing with the shortage of PPE, the next best option is extended use N95s with a face shield that covers it. And we know from science, the more we're taking those masks on and off, the more potential we have to be infecting ourselves as we take that on and off. So extended use N95s is the second best policy there. If that face shield isn't available, that extended use N95 with goggles. And then we get into some of the newer things that have been happening. So just yesterday, OSHA made some additional approvals for N95s that come from overseas that, for instance, the Chinese KN95 To be honest with you, this is all new and we're looking into it right now, so I don't have a lot to discuss about that, only to say I recognize that that's happening. When we're talking about limited reuse of those N95s, again, I just want to remind healthcare workers that you are at risk for contracting that COVID-19 the more you're taking on and off that mask. That multiple donning and doffing can really increase your risk for contracting COVID-19. Also, when we're talking about that limited reuse, there's a lot of talk out there about getting 5 N95s and you use one on one day, you use the second one on day 2, 3, 4, and 5, and then you cycle through them again. If we look at the precautionary principle, there is some research out there that the COVID-19 or the coronavirus lives on surfaces longer than what there might be projecting with that 5 days. So that 5-day reuse of N95s really isn't best practice either. So then the next thing that they're going to is the whole decontamination. And in order for decontamination to work for PPE, it needs to be able to be, number one, safe. It needs to be safe for you. And number two, it needs to be effective in that it removes the pathogen from that mask, if we're talking N95s, while also not degrading the performance of the respirator, including the filtration, the structural integrity, and the face seal. And I just want to read a quote from you here. The CDC and OSHA do not recommend that FFRs be decontaminated and then reused as standard care. This practice would be inconsistent with their approved use, but we understand in the times of crisis, this option may need to be considered when FFR shortages exist. However, no current data exists supporting the effectiveness of these decontamination methods specifically against the coronavirus. So they haven't found anything that's safe. The National Nurses United went through some of the ways that are being discussed for decontaminating N95s and did not find any ways that were both safe and effective. And I'm just going to go through these very briefly. The first one is the vaporized hydrogen peroxide. So if you're like me and a child of the 80s and you hydrogen peroxide your hair, you know breathing in those fumes are not good for you. They can create respiratory symptoms, including upper airway irritation. That contact with your skin can cause irritation, and high concentrations may damage the trachea and the bronchi. So the FDA recently approved through an emergency use authorization this vaporized hydrogen peroxide. And here's the problem with that. First of all, the research that was submitted originally back in 2015 was found to be inadequate. It got resubmitted, and because of this pandemic that we're having, they approved it for this use. But again, the research, when they first looked at it, was not adequate. It has not been shown to be safe for people to use. And additionally, some of the materials in N95s, particularly cellulose, are incompatible with hydrogen peroxide, so it degrades, so it's not effective. The next one that's being talked about is the moist heat and steam. The problem with that is it could potentially damage the respirator and that really important seal that we need on the face. Again, I'm going to quote from the CDC. One limitation of the moist heat method is the uncertainty of the disinfection efficacy for various pathogens. In other words, they're not saying it's safe. The next way that people are talking about is with UV, and UV only decontaminates the paper, not the actual filter. And it can also degrade the straps so that you're not able to keep that tight seal on. Some of the other ways that are being discussed are the ethylene oxide, which is a known carcinogen. Oofda, that's a hard word. Also microwaving, which can damage the nose foam and also damage the strap. So again, you're not going to be getting that tight seal. Bleach has been discussed. but we know that inhaling chlorine gas can lead to irritation, to breathing difficulties, coughing, and potentially damage the lungs. And lastly, that ionizing radiation has been found to create some damage on the filter. So there is no decontamination method that has been found to be both safe and effective. So then we move into bringing in your own home supplies. So I know we have all seen the Joint Commission on 331 just came out with a statement that says the degree to which privately owned masks and respirators will increase the protection of healthcare workers is uncertain. However, the balance of evidence suggests that it is positive. No Joint Commission standards or other requirements prohibit staff from using PPE provided from home. If the group that won't let you have a drink sitting next to you while you're working says it's okay, I think we can go by that. The problem is hospitals in some situations aren't letting us bring in our own PPE. Nurses should not be retaliated against for bringing in their own protection. As far as it scaring the patient, it's malarkey. I think we can all agree. Patients are probably scared entering the hospital to begin with. I think they'd be more comfortable seeing a nurse taking care of himself or herself by having the appropriate PPE. And then the last thing that I wanted to hit on is the homemade masks. Homemade masks are source protection. They are not provider protection. Remember that the CDC does not consider these PPE. Their capacity to protect healthcare workers is unknown. The CDC states that caution should be exercised when considering this option. The Joint Commission stated homemade masks are an extreme measure and should be used only when standard PPE of proven protective value is unavailable. They are a last resort. We don't know how well they work. I know there's a bunch of people out there that are MacGyvering different types of homemade filters and using different types of materials in an effort to protect themselves. And I understand how you're feeling about that. But again, I just want to emphasize that the research isn't strong that they're protective. And remember that your employer has the legal, the ethical, and the moral obligation to provide you with appropriate protection. Thank you.
Okay, and this is Jerry again. I'm sorry, I should have mentioned that because we have hundreds of nurses on this call, we're not going to be able to take individual questions one at a time. But if people can type into the question box their questions, I will compile them and then ask them of the presenters, and we'll do questions after the first three presenters. I hope that sound isn't me. Okay, it's not me, but someone needs to mute themselves, I think. The next, our next speaker is Carrie Mortrud, who is our nurse staffing specialist. And Carrie, whenever you're ready, go ahead.
Okay. Hi, everybody. I think I can speak for Kristina, Jackie, and myself that we would much rather be in a room with all of you at the MNA office or up in Duluth or down south where we can actually see and interact with you. But you all know the situation, so we're doing the best we can, and we're so glad you took the time to spend some time with us this afternoon. And again, as Jackie said, if we don't get to your question here, feel free to continue to submit them, and Jackie and Kristina and I will get to them as well as we can, as fast as we can. So again, I'm Carrie Mortrud. I am your nurse staffing specialist. I was a nurse at Abbott Northwestern for about 9 years on the cardiac telemetry and cardiac ICU units, and a steward and chair there, and then I left and I was a lobbyist for you all for about 8 years. And now, like I said, I work on staffing issues. So all of the concerned staffing forms that you guys fill out come to me, and then I assist with teaching classes, problem solving, helping with proposals for negotiations, etc. So the last thing I want to mention before I talk about my section is that a lot of the information we're presenting today is on the FAQ that is posted on the MNA website. So if you need to refer to something, again, a lot of that information is there, and as we get new information, we try to update it. It is getting quite large. So there is a table of contents at the beginning, so you can try to sort through and see which topic you need, but just to give you another place of reference. So one of the biggest questions people have right now is, can I refuse an assignment? Can I refuse a patient? Can I refuse a COVID positive patient if I don't have the proper PPE? So prior to COVID, some of you might have attended or some of you might know that we go around and do a lot of education sessions, and one of the sessions we hold is called Responding to Unsafe Assignments. Previously, it was called Refusing Unsafe Assignments, but we started to get a little pushback from some of the hospitals. They started refusing to let us schedule classes in there in the hospitals because of the language, etc. So we tried to be a little sneaky and offer a different name, but all of those principles still exist when it comes to responding and refusing an unsafe assignment. If you have patients that are too high acuity, the nursing intensity is too high, you have too many patients total, you are not trained on specific equipment, or you are not trained on a specific patient population and do not know the standard of care, you can and should refuse an assignment as it is assigned to you. Never refuse to work, but you can and should refuse an assignment based off of all of those principles that we have taught and talked about before. Now, when it comes to the situation we're in right now, you can and should advocate just as hard and just as much for the patients that are not COVID positive and not admitted to be a rule out. So right now it feels, and it is very apparent, that your employers are putting you in a situation of almost having to choose which patient and whose care takes precedence. And so the one thing we want to make sure you know is that we want you to advocate and make sure that you don't have mixed assignments. You should not have a COVID positive patient, a COVID rule out, and then non-COVID, non-rule out patients all together in one assignment. And then if you're in the situation where they are giving you an assignment and you don't have the proper PPE, talk about the fact that you are still interacting with non-COVID patients, non-COVID positive staff, obviously, etc., and that you need to have the proper protection to protect everyone else. We're not saying that obviously your health and safety and wellness, your families are not important, but we know the one thing the hospital can't and shouldn't refute is you advocating for the other patients that are not there for COVID positive, COVID rule outs. So a sample statement you could make is, like I said, don't say I can't care for a specific patient or that patient because they're a COVID positive patient, but say that I'm not going to put the other patients that are assigned to me at risk. So if you have the proper PPE, offer to take the COVID patients, maybe have them cohorted so you and another staff that have the proper protective equipment are caring for those staff, but you're not mixing with the others. So again, I'm not refusing to work, but I am refusing this assignment as assigned to me. if it's helpful, not to give you one more thing to do, but look up the hospital's mission statement, or if they have a nursing philosophy statement. It's very handy to use these in these kinds of situations. I know a lot of the mission statements claim to the community they serve that they will be ready and prepared with all resources necessary to care for patients when they and their loved ones need it. Well, this is a situation where they are forcing you to work with less than what you are supposed to have, less resources, less PPE, less staff, all that, and use that how are we living up to this commitment we've made to the community when we fall short like this. The last thing I want to cover is, I think a lot of times some of our nurses feel like if you're in a closed area, so even women care, I know a lot of procedural areas are closed right now, but especially the ED, that you are still held accountable to the Nurse Practice Act and to deliver safe care. Just because the emergency department has to follow EMTALA doesn't mean that you have to rescue them from all of their staffing disasters. So EMTALA is the federal mandate that when someone shows up to the emergency department, they must be seen. And that is accurate, and it's no different right now. However, it's not your job as an individual nurse to solve that problem if there aren't enough staff, if there aren't enough pieces of equipment, etc. It is the hospital's responsibility. And I would just encourage all of you that you do have to be accountable and responsible for the care you give. So don't take more than what you can safely deliver. As an employee of the hospital, obviously you have to follow and be part of the requirements and regulations that they are responsible to, but don't solve their problems for them. They are very good at just walking away and letting nurses, argue amongst themselves or take on more than what they should and disappearing. So we know from research and experience that a lot of times nurses are questioned after the fact. What did you do to resolve the situation? Did you call up the chain of command? Who did you notify? And so we know it's not a reasonable response to say, well, it was the weekend. There's no management here, or there's no administrator on call, because there always is. We know that there always is someone on call. So if you don't have the resources that you need, make sure that people are calling up the chain of command. And finally, in the emergency department, a lot of nurses talk about when you're already full. The ED is full and we've got an ambulance coming in. We can't just, abandon those other patients. And that's true. If you're an ED nurse and you have a full assignment, but you're assigned to take the next ambulance coming in, work with the charge nurse, get the supervisor down there, get someone on the phone that can come take report on the patients you currently have in your care so that you're free to go take the ambulance. Because as Jackie and Kristina and I have talked and learned, if you still maintain care for those 2 or 3 patients you have in the ED, then go try to take the ambulance that's coming in, nurses have actually been accused and charged with patient abandonment because they actually couldn't deliver care to those other patients that they had been assigned earlier. So I know it's easy for me and us to say these things, through the computer on a camera, but trust me, the hospital, once you start holding them accountable, will have to start answering. And we're available to talk through any specific situation you might have. And, as cheesy as it is, we're all in this together and we're here to help you guys. So with that, I think I'm going to close. And as Jerry said, we're going to take questions after Jackie's done, for myself, Kristina, and Jackie when Jackie's finished. Thanks.
Okay, thank you so much, Carrie. And just a reminder that this is a very complicated issue, and there are a lot of nuances. And one of those nuances is that every single situation is different. Every employer is different. Every facility is different. Even every unit is different. And so we may not be able to get to questions that are extremely specific to a particular situation that's very, very specific, but we'll do our best to address questions. Then if you still want to talk very specifically about what's happening in your bargaining unit, you should definitely reach out to your MNA chair or your labor rep who can help you problem solve that issue that is specific to where you work. So next up, we will hear from Jackie Russell, who is our practice and regulatory affairs specialist. Thanks, Jackie.
Hi, everyone. Yes, so my name is Jackie Russell. I am a registered nurse. I've been a nurse for over 20 years. My primary area of practice was emergency and trauma. And I just want to assure you that I do understand the anxiety that goes into getting ready for patients who are critically ill, that you either feel you're not prepared for yourself or that your hospital is not prepared for. I have worked in remote critical access hospitals, community hospitals, and level 2 trauma centers. And so my topic is deployment and floating to units where nurses are not familiar or experienced. And a lot of this comes from my own experience, but also I'm an attorney and I have a special interest in nursing malpractice and discipline issues. So as for deployment, just want to go over briefly some of the key points that we're seeing and trying to address that we've seen in different hospitals throughout the state. And one of the keys to success in mitigating the COVID-19 pandemic is, as we all know, discontinuing the elective surgeries and training and reassigning or deploying non-ICU and non-ER nurses to other areas of the hospital where their nursing skills are most needed. As we see the increase in critically ill COVID-19 positive patients, or anticipate seeing an increase in those patients, hospitals are preparing by expanding units, creating new units, and floating or deploying nurses to work in areas where they don't have experience or maybe haven't worked in for years and no training. The Society for Critical Care Medicine recommends a tiered staffing model for hospitals opening new ICUs in response to the pandemic. Already, we're seeing hospitals that have adopted this model. Already, we're seeing OR and labor and delivery nurses, for example, expected and anticipating to deploy to ERs and ICUs where they have no experience and are rightfully concerned about their competency and their hospital's expectations. Another important step in mitigating the spread of coronavirus, as we all know, has been social distancing. Applying this principle to hospitals to mitigate the spread of coronavirus, it is important that hospitals pay attention to the engineering or how they set up units. And this is where nurses can play a very key role in helping set up these units, and primarily to avoid mixing coronavirus and non-coronavirus patients, as Kristina mentioned in her discussion at the beginning. We've seen some hospitals that have done this very well, and other hospitals that are still mixing non-coronavirus and coronavirus rule out or positive patients, and nurses that have assignments between the two patient populations. So nurses, you're on a great position again to be an active participant in organizing your unit and setting up teams and deciding how best to approach and care for rule out patients and coronavirus patients. When and if you are deployed to a unit that you feel is out of your scope of practice, Look at what you can offer your unit and do not accept assignments that you do not feel safe caring for, that you don't have the experience and you have not had the training for. There are a lot of other roles that you can play. Remember, we're getting ready for a surge, or you're getting ready for a surge, and the surge of patient population are the coronavirus. They all have respiratory. So in conversations with nurses, like labor and delivery nurses being floated to the ER, it would not be expected that a labor and delivery nurse care for a trauma patient or a patient that's having a heart attack or a stroke or other high acuity ER patients. But there is a role, because if there's an influx of respiratory patients, then nurses who don't have the experience with the higher acuity ER patients can help to triage respiratory patients, vital signs, be part of the team, basic assessments, routing patients where they need to go. There are many, many roles that you can play that don't put you in a position to care for patients unsafely. So really, this is just basic info. I know that every situation is different, and really we just want to give an overview and hear from you what your situations are. Just know that we're here for you and we're happy to help you in any way that we can. Please feel free to reach out to us at any time.
Okay, so we have a great bunch of questions to address, and we'll try to get to most of them. I don't know that we can get to all of them, but I'll try to combine some if the topics are similar. So the first one is from Patty, and she's asking, what's the plan for discharge to long-term care or TCU as far as testing? And COVID may not have been diagnosed, but the patients I care for are vented in LTAC at Joe's 4100. Seems semi-questionable to send them to TCU or long-term care after hospitalized and potential exposures. Is there a best practice for this? And I'm not sure who would like to take that one.
Well, this is Jackie. I would share that concern. It does not seem like a best practice. So if I understand right, this is a rule out, or is this, Jerry, was this a positive patient that's then being transferred to a unit?
My understanding from reading the question was that it was someone who wasn't able to get tested, so we don't know their status. I hope that's right.
So this is where, I really advise nurses participating in just being very active in how and where the patients are going to go. Again, setting up the unit, or even in the transfer of them to unit. Again, this is putting other patients in harm's way, which it's a very valid concern. And so what is best practice is not transferring the patient to potentially expose other patients. What are the options? Is really looking at your unit and what other options you have within your hospital. If you want to reach out to me so that we can discuss that a little more, I'd be more than happy to review what that plan might look like, so we can address that maybe more individually.
Okay, thanks, Jackie. The next question is from Lisa, who asks, I work in a non-patient facing area. The email she got yesterday said cloth masks only. If not everyone in my office wears them, I'm not really protecting myself. Why can't I wear a better mask from home? This seems very negligent. Kristina, you want to take that one?
Oh, I'm unmuted already. Yay, it worked this time. I really, this is me personally, really struggle with cloth masks because there's so many unknowns, and I don't know why you can't wear your own from home if you're talking about surgical masks. I know people are out there using the cloth masks, but remember, everyone is talking about them, from the CDC to who else did I mention? The CDC, blah, 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 JACO. Even in Minnesota, I wrote down the code exactly. Our Department of Health Commissioner Malcolm yesterday on the call, when talking about these cloth masks, said, and I quote, "Masks can help with your germs infecting others, but that," and again, quote, "these are not masks that prevent the wearer from contracting the illness." So you're better off with surgical masks if you have it. Does that answer your question?
Okay, I'm not able to see real time if that answered the question, but thank you. We can. I'll tell you if I see another question that comes in about that one. The next one is also for Kristina. So how long? And this is from Desiree. How long are the surgical droplet masks good for? I've heard only 4 hours if we're constantly breathing into them.
In a perfect world, the way that we were all taught in nursing school, it's a one use only. We're into uncharted worlds, uncharted territory. There's some evidence that the coronavirus can live on those for 7 days, I think I've read somewhere. I'd be more concerned with the donning and doffing of them. So if you are leaving them in place, structurally they're sound, you're not touching them and then touching your eyes, but again, we're into uncharted waters right now with how long these can actually be used.
Okay, I've got another one for Kristina. You are very popular in the comment or in the question section. A couple of different people asked about how to address home care nursing concerns. So agencies and home care units are telling nurses to go into patient homes with minimal protection. What would you recommend nurses do in a home care situation? Is that any different than what you would recommend in a facility setting?
So this is a little bit personal for me, as for those of you that don't know me, I have a daughter who works not in home care, but she works as a nursing assistant, and they are giving out those homemade masks to my daughter, and I am just about ready to go show up there and pull her out of that unit as a mom, because again, I'm afraid. I think as nurses, we need to make sure ultimately, first and foremost, that we protect ourselves and that we take steps and do whatever we need to do to protect ourselves. And I'm just going to share a really quick off story. I also teach the BLS classes here for MNA, and I think we've done maybe 12 classes or so. And in every single class that I've taught, the hardest thing for nurses to do is that first step of ensuring that the scene is safe. Every class, nurses are running in there to perform their CPR without checking to make sure that the scene is safe. And so my advice to you is to advocate for yourself, that you are appropriately protected when you're going into people's homes. And I don't know what else to say beyond that, but your safety, your health is important and needs to be protected.
Jerry, if I could add to that, this is
Yes,
Jackie.
go ahead.
So for home health, and I hear some have done this, I don't know if all home health agencies are doing this, but pre-screening patients before they go to the appointment is critical, and then preparing with the proper PPE for those patients. And of course, I know home health nurses, like all of us, know what the proper PPE is, but also is when you're in the home and doing your assessments and care, is to ask family to not be in the room with you, primarily because you've screened the patient, but you haven't screened the family. And again, they are another point of contact for COVID. So you want to, mitigate transmission as much as you can. And that is one step, the PPE and the pre-screening. And I'm still actually doing research on home health and what best practices are for coronavirus, because I've had this question just recently. But just in my limited research, those are 3 key tips to get started with. And please email me if you need some further information, and I can provide to you the research that I find in addition to that.
Okay, thank you, Jackie. And I just want to let people know that we will be sending out an email after this webinar with a lot of resources, maybe more resources than you want, but we'll send out lots of links. Jackie just offered her email address. I'll put that in there. And we'll do our best to, if we didn't address your questions in the Q&A, that we'll send you resources that you can use. We have time for one more question, and then we're going to move to the next part of the agenda. But this one is going to be hopefully a quicker one, and it's for Carrie. Can nurses be mandated? This is from Fanta. Can nurses be mandated to work more or stay at the hospital for periods of time? Can you talk about how overtime works in a peacetime emergency?
So this is a great question, and we actually might want to talk a little bit more and be part of the solution in this situation. There's research out there that talks about offering or asking staff to work extended shifts so that they are coming in less. So there'd be less in and out and less transfer of care from, instead of 3 nurses in a 24-hour period, you would only have 2. So our mandatory overtime statute protects the nurse from retaliation when you refuse to work beyond your scheduled shift because patient safety would be at risk. But the exception to that is a state of emergency. So what I would encourage people to do is that still make sure that you're protecting yourself by protecting, which will then protect the patients, right? So if you are too exhausted, if you've done an 8, a 10, a 12, a 16-hour shift, I would really, really caution you against doing more than that if you feel unsafe, and put patient safety first. But we might want to talk about on the local level at your hospitals, within health systems, on how we want to address the idea that maybe we should look at longer days, but then less frequency, so that we can decrease the amount of exposure for everyone.
Okay, thank you, Carrie. So now just to keep up with our agenda, and if we do have time later after we finish up with the formal part of the agenda, we can try to come back to do a little bit more question and answer. But we want to hear some success stories from the field, from nurses who have encountered some of these challenges that were discussed in the questions, and what they did and how they came up with a solution. So the first person, and I hope we can unmute her, is Jennifer from Grand Itasca. Jennifer, are you on the call?
Can you hear me?
Yes, go ahead.
Okay. Hi. Thank you, guys. So on Monday, March 30th, we, the nurses at Grand Itasca Hospital, we did an action to our president and CEO. The nurses flooded her work email with letters voicing our concerns in regards to recent changes in policies. Some of the areas that nursing had concerns with are PPE. We still don't know at Grand Itasca what our current inventory is of PPE, so we don't know how concerned we need to be. Also regarding PPE, it needs to be available when the nurses are requesting it. One of the nurses that I work with, she will be talking about an issue specific to that next. We need more education on PPE, and also training for the nurses that are being floated into other units that they don't normally work. Staffing, we asked for a reduction of patient assignments when caring for a person under investigation or with confirmed COVID. Again, access to PPE. Grand Itasca is talking about furloughs and reduction of hours for nursing staff in certain departments. That already has happened. We want these nurses trained in other departments to prepare for the possible surge of COVID patients instead of the furloughs and the reduction of hours. Communication, we are requesting frontline RN be present at all meetings where COVID preparations are being discussed. Currently, management is not really talking to the nurses to get our opinions, so we'd like more of that. And nurses are requesting that they want to be notified that when we do have patients that we're testing for COVID, they do want to know when they have cared for a patient that has tested positive. So that was our ask. We presented it to our members. We activated our CAT team and we made a whole bunch of phone calls. It was pretty easy to get the nurses on board with this action because the nurses are concerned. This is, you know, what they're concerned with. And so it was very easy. Within the first 3 hours of our action, me and our chair were in a meeting with our HR director. And within the first 3 hours, over 40% of our nurses had already emailed our president and CEO. So we were very happy with the response from the nurses that we had. One of the other big things that the nurses want currently at our hospital, if we would happen to get diagnosed with COVID, we have to use our sick time in PTO. Their stance is that unless we had a failure in our PPE, how do we know, or how does Grand Itasca know that it's not, that we didn't contract it from the community? We did get a response from our CEO. She emailed everybody who had emailed her. Her big things was that her top priority is the safety of staff and patients, that they will reevaluate PPE policy as needed as the experts learn more, and also supply changes. So that one worries us significantly. And she did take a personal message. She said that for us nurses to say that management has a disregard for the health and lives of our patients and safety is personally insulting and hurtful. Pluses within the next day of our action, one of the directors of our medical surgical pediatric floor, they were making some changes on the floor. They pulled in some of the nurses, was asking their opinion, how they should set stuff up, and trying to get the actual frontline staff involved. So hopefully we will see that in more of the departments. That's what I got.
Okay, thank you, Jenny.
Thank you.
And sorry, we're also, I'm not sure if she's on the call, but we're also planning to hear from Chrissy Maddie, also from Grand Itasca. Chrissy, are you on the call?
Yep, can you hear me?
Yes, go ahead, please.
Okay, so thank you guys for letting me be able to speak. My name is Chrissy Maddie. I'm a registered nurse in the radiology department here at Grand Itasca. And basically I'm just gonna kind of tell you guys what happened. I'll give you a little bit of background. My situation involved orders for a thoracentesis, an ultrasound guided thoracentesis on a very dear patient who I have developed a really close friendship with over the last 2 years caring for her. in a professional sense. I know her really well. I care very much for her. She happens to be on a transplant list and requires these thoracenteses occasionally. She had some imaging done in our ER, which revealed a recurring pleural effusion. She had a cough, shortness of breath. And for the purposes of confidentiality, I'm just going to call her Jane. So Jane was admitted through our emergency department and was tested and was waiting for the test results for her COVID-19. So she was placed down one of our hallways that we have designated on the medical surgical floor as confirmed or PUIs. So this happened on March 27th. The attending physician indicated that she wanted this patient to have a thoracentesis done. I had arrived at work around 8 a.m. and was told that Jane was an inpatient. So I started doing some phone calls to the medical surgical floor and the schedulers by about 8:45 that morning. After discussing the orders with the attending provider, we determined that this procedure was truly necessary for her condition. So I began to plan for the procedure. First, looking at kind of our latest procedure guidelines, and that would direct us to keep the patient in her non-negative airflow room, just a regular patient room, instead of taking her over to the radiology department just to cut down on unnecessary transmission throughout the hospital since she was a PUI. I reviewed the current PPE guidelines on Fairview's website, which is who we get our direction from, and I was kind of surprised to discover that Fairview didn't list ultrasound-guided thoracentesis as an aerosol generating procedure. So I walked over to our general medical floor and actually ran into one of our house supervisors near that hallway where we were keeping our PUIs. I asked her about getting a PAPR hood because I have failed fit testing. I can't taste the bitters. I was told by this house supervisor that and I quote, I didn't need it. She instructed me to use only a surgical mask, one on the patient and one for me, using a face shield for myself, and then, the usual gloves and gown. I didn't feel good about it, and I told her I disagreed with that, and that I would not agree to do the procedure with the radiologist until I had the proper PPE, and was met with pretty large amount of frustration on her part. She huffed and said she would go talk with the attending physician. I just asked her to call me back. So she returned my phone call very flustered and repeated to me that I didn't need the PAPR. I was met with more resistance when I told her that I still continued to disagree and I wanted them to consider the procedure an aerosolizing procedure. She said with another huff that she would ask and call me back. She returned my phone call this time with the Senior Director of Quality and Safety on the line. So I'm thinking, this is good news. I have somebody, in leadership that's going to be, that's going to protect me and get me the PPE that I needed so we could quickly get this procedure taken care of for this patient. They told me both that I didn't need the PAPR, and this Director of Quality and Safety spoke to me in a very harsh tone and underlined that she said this was not an aerosolizing procedure. So at that point, I contacted my MNA rep, Jenny, the one that was just speaking, and explained the situation. She immediately got on board and began communicating with leadership here as well as incident command for COVID-19. So by this time, it was about 10:30, and there was no way that we were going to be able to get that procedure started on time. But I refused to be pushed just because there was urgency in getting the procedure done. I really wanted what I needed to do this procedure safely. Leadership then began to bully the radiologist who would be performing the procedure, as well as a junior nurse on the med-surg floor, to do the procedure without N95 type gear. I was feeling continual extreme pressure from leadership to do the procedure, and it was really uncomfortable. I gave them copies of the CDC's recommendations, which state, and I quote, "In particular, procedures that are likely to induce coughing should be performed cautiously, and that if performed, the following should occur. Healthcare personnel in the room should wear an N95 or higher level respirator." Still, they insisted that this was not aerosol generating, even though I'm sure many of you on the line will agree that a thoracentesis in many, many, many cases ends with coughing. I was able to find a peer-reviewed study that stated a surgical mask on the patient, as well as a surgical mask and eye protection on the nurse, was insufficient in protecting the nurse from a cough. At that point, two MNA reps accompanied me into a room with the VP of Hospital Service and the Senior Director of Quality and Safety. Those reps both witnessed senior leadership use harsh, condescending, pushy kind of language with me, and finally the quality director threw her hands up in the air and just said, "Just go get the PAPR, because the patient has been waiting for over 3 hours." They also shorted us on the ultrasound technician. It was decided by leadership that the radiologist and me as the nurse could adequately perform this procedure for this patient, just the two of us. So by now, over 3 hours had passed, and my employer decided to withhold much needed patient care. I mean, they had the authority to do the procedure safely, and yet they chose to maintain their resolve, and thus ignoring valid concerns by nursing and the radiologist. They lowered patient care standards by not allowing an ultrasound tech to do their job, and ultimately allowed my dear patient, Jane, to suffer in discomfort for hours. Despite my frequent communication with leadership at the local and system-wide levels, thoracentesis still has not been added as an aerosol generating procedure, even though that CDC names it, specifically any procedure that induces coughing. So I'm just asking that you nurses would see what is going on in your facility, what your system recommends. I personally have filed my complaint using the super nice MNA COVID-19 incident report, and you can find that online. The website for that is www.covid19form.com. And I've also taken this a step higher. I have registered a complaint with the Minnesota Department of Health and OSHA both. So just nurses, continue to speak up, ask for your MNA reps to witness any conversations, especially if leadership is being difficult, and stand your ground for what you know to be right about your daily patient care. Thank you.
Thank you so much, Chrissy. That was really helpful to hear your story. And thank you, Jen, as well. It was very helpful to hear from you. We're going to move on to the next part of the agenda. We'll hear for a couple of minutes from Phil Denniston, who is our Director of of Field Operations, who is going to talk about some other actions that nurses have been taking across the country. And we'll have some visuals on that too.
Thanks, Sherry. So in the two panelists you just heard before, one of the things that is sort of a central theme that's emerged throughout this COVID crisis is the fact that despite us having collective bargaining agreements that have protections in them, that have safety provisions, and some may not be specific necessarily to a pandemic, but some have emergency provisions, and generally the language in our contracts, there are some employers out there that have taken advantage of the crisis and just tried to ignore our agreements that we've made. And it's led to a lot of problems. And in order to use your traditional grievance mechanism that the employers are trying to sort of ignore at this point, or unfair labor practices or the National Labor Relations Board, the one thing is really clear, and you'll hear this from our reps pretty regularly, but it's that in order to make management do the things that they should be doing right now, relying on the contract isn't going to be something that is very simply going to get you a resolution to the problem, right? This is like days of unions when, without a collective bargaining agreement, what people want in terms of protections for themselves is acting collectively with actions to force management to give them what they ought to have. In a pandemic like this, obviously, it should not take that to make change and to have yourself protected. But unfortunately, that is what's happening in some facilities, not all, but some of them. What our members are doing across MNA and what's happening with NNU and other nurse union members around the country are actions, sometimes at the floor level, sometimes within a whole hospital or bargaining unit, and sometimes throughout a whole union, to try to hold management accountable to protect nurses. There are PPEs that are in short order, but the fact is there are things within management's control that if they don't control, people will die unnecessarily. And that is, for our members, unacceptable. And the way that we have been trying to counter that is making sure that the things management cares about most, oftentimes, more so than even the patient care they ought to be giving, is the perception of the patient care that they're giving and the public knowing what's really going on inside the facilities. So like actions you've seen before, you'll hear about our COVID-19 forum in a moment. I won't go through that too much, but our members are doing things like within the Health East system. There was a vote of no confidence where an overwhelming majority of our members voted no confidence throughout the Fairview Health East system, and in an effort to hold management accountable and the public. And they are now escalating and doing a photo social media campaign, holding up signs saying what their value as a nurse is. And we're beginning to roll those kinds of actions out as an option for members who need to take those to get what they need throughout. So if you are having mixed patients, if it's rule outs or positives along with negatives, then you're wearing the same mask, and it's all these issues that the resolution is frankly going to come through you and your colleagues standing together. What you see in this photo is an example of some NNU members that are doing an informational picket. And these have been very effective throughout the country. They are standing with socially distant, minding that, but taking small actions, sometimes at shift change. But they're doing these things, and if it's an actual picket, we still have to serve our traditional 10-day notice. But these have been very effective in getting press. You see the rope in between members to keep them distant. We've talked about if we were to do it to make sure hospitals understood what's coming if they don't react, us doing a chalk line with slashes on the sidewalk to show 8 feet apart or so for each person who's participating, so the hospitals know what's coming if we were to do it. There are things like that we are considering. There's social media campaigns. What we're encouraging everyone to do when you have these problems, whether it's what you just heard in terms of, one or two nurses sometimes having a problem with not getting what they need, they should, as much as we can, act collectively as well as stand up for your practice. So we're encouraging you all with your shop stewards, with your chairs, to start talking through what kinds of things can you do to express to the public how hard this is and what you need from your employer, because unless your employer feels like that is happening in the public, they may in fact not make the changes. And in many cases, we will say that from some of the actions we did with the example we used with mHealth, the surrounding health systems are actually behaving in a much better way. And so if any of these employers dig in, we should be making a point. So if you have any, also, by the way, it's very important that we collect stories and that nurses who want to speak out and tell their story, we do video vignettes, if you want to call it that, and video clips. We can do them for different hospitals, or we can do them MNA wide. to add to the kinds of video testimonials that are really moving the public and expressing the kind of frustrations of what you have to face every day. We would encourage you, we're going to do some training on that, and you'll see some emails. Look out for those on public speaking training on what to be mindful of when you're talking about these issues beyond just HIPAA, how to make sure you and your colleagues are protected when you speak out about these things, but people should feel empowered to speak out. We're going to help give you the tools to make sure that you feel comfortable and you know what your rights are when you're talking. So we encourage you to do these actions, to work with your reps, your chairs, your stewards, to take this on and not rely solely on the contract. Sure, we'll file a grievance, but at this point, it's too important. We have to resolve the issue immediately. So we'll continue putting pressure on all the governors in the surrounding area, all of the executives that are working in all the hospital C-suites. We'll continue doing this work. We're working with some of them well and others not as well. So we just encourage you, for any of you who want to push back and demand better, to let us know, and we'll work together to make that happen.
Okay, thanks so much, Phil. Our final speaker, and then if we have time after he is finished, we will try to go back and do some more Q&A. We'll hear from Chris Rubish from Essentia Health in Duluth, and he's also a member of the MNA Board of Directors. Go ahead, Chris.
Hi, thanks everyone. Thanks for joining us. So I wanted to start off with a couple things that we can be doing going forward, kind of related to what Phil was talking about in terms of things that you know, we can do as nurses to raise our voices and continue to protect ourselves and our families and our patients. So the first thing that we're trying to do as a board, as it was mentioned, I'm a nurse up here in Duluth at St. Mary's Hospital, a telemetry nurse, and I'm also a member of our state board of directors. And so one of the things as we're trying to advocate for nurses, not just around the state, but you know, across the region, is the Pandemic Bill of Rights. And this is a petition that we're trying to gather statewide and indeed region-wide with our nurses in Wisconsin, North Dakota, and Iowa. And we're trying to gather signatures to send to our lawmakers in these various states to get either governors to take executive authority action or legislatures to take executive action to assert our rights to safe and healthy workplaces. So I know you can't see the entire petition here, but if you follow the link, I know that this link has also been sent out via email to all of our members, and it's on a lot of our bargaining units Facebook pages. And it asserts our rights to have things that our previous MNA staff people have talked about: the proper PPE, safe assignments, training for donning and doffing, and just making sure that we're doing these things to protect, like I said, ourselves and our families and our patients. And just as a little aside, I know it can seem like, gosh, I'm signing these petitions, I'm just kind of shouting into the wind, what is really happening? What does my voice do? I just wanted to share an anecdote that up here in Duluth, we had nurses who were really frustrated by the talk of Essentia possibly laying off bedside care nurses. I know that many facilities across the state have been dealing with changing economic situations as we have clinics and outpatient surgeries being canceled. And we felt that that was a really wrong move for Essentia to be making when we're on the cusp of likely seeing large patient volume increases as COVID comes to the Northland. So we had nurses write emails and letters to the governor, and actually found out through some very angry exchanges with our HR department that the governor actually called all of the board of directors of Essentia and leaned quite heavily on them to not go into nurse layoffs. And so at least at the moment, we have not seen any nurse layoffs from Essentia. And so it's just an example to show that when you do things like sign these petitions, write letters to the governor, reach out to your lawmakers, they are listening to us and they know that we are on the front lines and we know what we're doing and what we need to care for our patients safely. And then the second thing that I'll go into is also just reiterating what Phil said about the COVID-19 reporting form. So this is going to be kind of similar to our unsafe staffing forms that many of you have filled out. And we're going to be gathering these from across the region, and again, using them for principally for lobbying. Initially taking these to employers and hopefully showing them these are real world incidences that our nurses are experiencing, and we need their help and support. And if that doesn't work, we can escalate that to government officials. Like I said, the governor, Mary Turner, members of the board are meeting frequently with the governor, and he is listening. And if need be, as our staff has said, we can take these to the media and to the public. And we know that the public trusts us. We're the most trusted profession in the country. And so if needed, we can certainly take these stories and these accounts to them. And just to be clear, of course, as you fill out these forms, not only will they be vetted to make sure that there's no HIPAA violations, but either union stewards or staff members will follow up with you to make sure that, of course, you're okay with your story being shared, because we don't want to share anyone's information without their permission. So I know up here in Duluth, I've been reaching out to some of my fellow nurses who have filled these out and just getting more details and making sure that they're okay with us taking those forward and bringing forward their concerns. So please fill out these links. We need to collect your stories. This is what's going to help us turn the tide and keep us safe. And please just remember that if we work together, we can protect ourselves and our families and our communities as much as possible.
Okay, thank you, Chris.
Thanks.
And I just wanted to know if you heard any links or any resources that we've referred to. We will send those out as well in a follow-up email. I'm sure lots of people are rapidly jotting down notes of URLs and so forth, but we will send those out to you by email. Since we have just a few more minutes left, I did want to let you know we had a question in the question box about the number of petition signatures. As of this morning, we were over 6,000. Our original goal was 5,000, so we had to adjust that goal, and now we're shooting for 10,000. So if you haven't signed that already, please do sign the petition. Please share it with your family and friends, put it on social media. Anyone can sign it. Anyone who cares about nurses, knows a nurse, is just a good human being, ask them to sign it. Let's see. So now to go back to a couple of the final questions, we still have about 8 minutes. I have one that is for Jackie Russell. Jackie, are you still with us? Jackie, are you there? We might have lost Jackie. I apologize. But the question, and I can answer the short version of the question because I've heard Jackie answer it before, but we will get you additional information if we can. This question came from Jen, and it was basically if for nurses that are being trained to work in the ICU who don't normally care for patients that high acuity, should they be considering supplemental malpractice insurance? And the advice that Jackie has been giving to folks is yes. Carrie just joined us again. Did you have something to add to that, Carrie, or were you just popping back in?
Just letting you know I'm still here, and I'll just echo that yes, Jackie and all of us have said if the question is should I get supplemental liability insurance, the answer is yes. Doesn't matter where you're going.
Okay, thanks, Carrie. I have another one for Kristina. Kristina, are you still there?
I'm still here.
There you are. Okay. This is from Ashley, and she asked, you mentioned that we put ourselves most at risk when we're taking off our PPE. If staffing allows for it, is it ill-advised to remain in a room with a PUI or COVID positive patient to reduce donning and doffing frequency and to conserve PPE? Or are we better off exposing ourselves as little as possible to this patient population?
That's an interesting question, and to be blunt with you, I'm not sure. I would need to do additional research because I could see it both ways. So I'm sorry to be giving a non-answer unless, Carrie, you have better advice, but I honestly am not sure.
No, it's a great question. I think we'll just look into it because it brings up some valid points, and we should see if there's a pro and cons and which one wins.
Okay, we have another question, and this might be good for Jenny or Chrissy or Chris. This is from Melanie, and she asked, I'd like to hear more about how to talk to other coworkers that may be in denial and or how to expose workplace dynamics that keep RNs from questioning what is being asked of us. Many will accept unsafe PPE because the administration is insisting they're providing, quote, adequate PPE per CDC guidelines, unquote. But if the CDC is saying droplet is acceptable, then how can we justify only wearing an N95 or refusing an unsafe assignment on the grounds of inadequate PPE? So there's a lot in that question, but I think the first piece is how do you talk to other nurses, and how do you kind of raise up their awareness and give them a little courage? Chris or Jenny? Oh,
go ahead, Jenny.
Okay, thanks.
Yeah.
For me, it's talking about patient safety and then their safety. We never want to do anything that puts us at harm, and we never want to do anything that puts other patients that we care for at harm. And if you stick with just the basics of those, we can talk nurses into doing a lot, especially with the patient. Sometimes as nurses, we're okay, making exceptions for ourselves, but putting our other patients at risk, that's a big one.
Yeah, and I would say for me, just to kind of springboard off of that, not just talking to my coworkers about keeping their other patients safe, but also about keeping their family members, friends, roommates, whoever their living situation is. We have a number of nurses on my floor who share an apartment. That's multiple healthcare workers in the same apartment. These are the people that you are quarantining with. So you have the risk of exponentially exposing other patients. And so really helping them process that and think through that. What do these ramifications mean for me? And I guess I would say that when I have those conversations with nurses, I've had really great responses. In fact, a lot of nurses who are pretty new to MNA and to the union coming to me saying, wow, I didn't realize how important a union was. I didn't realize this is something that we could do. And it's unfortunate that it takes a crisis like this to make people realize that, but I'm glad that they are, because we have a lot of power together.
okay, thank you, Chris. Chrissy, did you want to address that one as well? Not sure if she's still with us, but we just have a few more minutes, so I think we can get to one more question before we wrap up, and this one's from Evelyn, and I think this is a good one for Kristina, or actually, probably a lot of people could answer this with how they would approach this situation. Evelyn asked, knowing I'm exposed to COVID with the best PPE possible, should I be self-distancing from my family? And I know that's a tough one, so there might be a lot of different opinions. So who would like to attack that one first? Can you unmute? Oh, Carrie wants to? There she is. Carrie.
I think Kristina should have taken it because she's actually still working. So, you have to do what's best for you and your family, especially if you have a family member that is immunosuppressed and or high risk. Always take that into consideration. We've heard and seen from nurses on Facebook posting that they want to, shack up with other nurses during this situation so that they are decreasing that risk, even to the community, their neighborhoods, everywhere. So I also saw another post on Facebook where the spouse had set up this really nice little area in their garage for his wife to come home and take off her dirty scrubs, wipe down, everything with Clorox, all this kind of stuff. So I think this is the time to be creative, but most importantly, protect yourself and protect your loved ones. Because in order to stop the spread, that's what we have to do. But we also are going to end up in a even more dire situation if all of our healthcare workers that are working right now get sick. So do the best that you can to take care of yourself, protect yourself the best you can. And, like I said, put yourself up there at the top with who needs to be protected as well.
And I would just add that that's another good reason for people to support and sign the COVID Nurses Bill of Rights petition, because one of the points it does highlight is asking hospitals to provide us with hospital provided scrubs, so that as well as showering facilities, so that you can be as clean as possible. We know that there's not going to be no risk, but it's significantly reducing risk for whoever it is who's in your home.
Okay, was there anyone else that wanted to address that one? If not, I will note that across the country, we're hearing about a lot of hotels that are offering deeply reduced hotel room rates for healthcare workers who don't want to go home and potentially expose themselves, the virus to their, or expose their families to the virus. So it's worth looking into hotels in your area to see if they are doing reduced rates. I know there's a number of them in the metro area and a lot of other places around the country. So at that, we are 1 minute over. It is 5:31. I want to thank everybody who joined us and who stuck with us for 90 minutes. It seems like we had a lot more questions than we could get to, so we are going to keep plugging away, putting out information on the MNA website, on the frequently asked questions page. We will send you an email chock full of links and resources, and we'll keep doing this work, and we'll let you know if we've been doing a few of these kind of webinars now, so we'll probably be planning something similar again in a few weeks. We'll be in touch. Thanks everyone so much for being with us.
Stay safe.